In a C patient of scoliosis, I will need to take a pertinent history, which consists of onset, whom noticed, when noticed, any progression, any activities limitation, and any neurology. I will examine the patient, expose the patient, assess the cervical spine from the back, front, and one sides. On the back, I want to make sure that check the deformity, it's right side or left side. Is the shoulder symmetrically equal positioned? The position of the neck, the position of the pelvis, and any asymmetry noticed. I'll make sure there is any cafe au lait spots or any birthmarks or any hair tufts, which will give me a stigmata or a perception of spinal dystrophism. I will ask the patient to bend forward and do an Adam forward bend test, and I will feel a bump or an elevation on the side of the deformity. On the side, I would like to check the coronal balance. In that case, I will check whether there is kyphosis or lumbar lordosis. Moreover, then after, I will also confirm by asking the patient to sit and then see the spine if it improves. This might be due to pelvic asymmetry, which causes the deformity. A scoliosis is defined as a 3D deformity in a sagittal, coronal, and axial plane with a curve angle of more than 10 degrees. There are two types of structural curve, which is fixed curve, and postural curve, which is flexible curve. The incidence is more in females than males. There are different types of scoliosis. Number 1 is congenital scoliosis. Number 2 is idiopathic scoliosis. Number 3 is neuromuscular scoliosis. 4 is a degenerative scoliosis. And 5 is a pathological cause of scoliosis. Regarding the idiopathic scoliosis, the cause is unknown. These are mostly large curves and they are below T8. They are basically below T8. Infantile scoliosis. These are developing in early onset. These are left side dominant, more commonly in boys. The problem is that the growing child would have deterioration of pulmonary functions and cardiac functions. These patients needs always MRI to avoid excluding syrinx or spinal dystrophism. Juvenile type is from age 3 to 10 years. These are most commonly on the right side, and there is a high risk of progression. If any suspicion of spinal neurolaxal abnormalities, we need to do MRI. In the adolescent sclerosis, again, it is right side common. Any left side deformity, we need to do MRI to exclude spinal dystrophism. Neuromuscular sclerosis are associated with CP, Duchenne muscular dystrophy, or polio, hereditary sensory motor neuropathy, or a cord tumor. They progress more rapidly, affect the respiratory system, causes balance issues. These are quite resistant to brace. The surgery is slightly different because sometimes needs a pelvic fusion to be added. These needs to be done sometimes quite urgently to avoid a walking child to continue walking, or in certain cases to improve the sitting balance. Regarding generally the treatment of scoliosis, if the deformity is above T7, it needs a Milwaukee brace, that is a CTLSO. If it's below T8, then T7, you can do a Boston brace. Up till 25-degree scoliosis, we can manage it on observation. 25 to 45-degree, we would prefer to do a brace, which is not always effective, but is to reduce the progression. And more than 45, a brace is contraindicated and possibly surgical intervention is indicated. Regarding the type of surgical intervention, it can be either posterior pedicle screw fixation, 2 levels below and 1 level above the stable vertebra. In higher deformity and resistant deformity and pediatric population as well, we need to go anterior also. Sometimes we need to do anterior release. Sometimes we would need to have anterior release and fixation to avoid crankshaft phenomenon in pediatric population. Regarding pathological scoliosis, it is most commonly in osteoid osteoma. Osteoid osteoma is towards the concavity of the cervical spine, regard towards the spinal deformity. Regarding the osteoid osteoma, there is a saying that if less than 11 degrees and less than 11 years of age, resection of osteoid osteoma itself will improve the deformity and you don't need any correction for this. These patients are slightly different because they are complaining of pain, which does improve with aspirin. Other causes of pain should be excluded like prolapsed disc, spondylolisthesis, or scoliosis itself.